On this topic, the two of us have probably been having a running conversation for longer than I want to admit, because I've actually known Patrick for quite a while. I'll leave it at that, or to your imagination for how long. But let me take a moment, if I might, to introduce Patrick. I'm sure you all read the bio, but just quickly, for those of you who need a little reminder, he currently serves as the CEO of Care Solutions at Optum, which is part of the United Healthcare Group. And he is responsible for leading a platform of innovative and value-based, big buzzword today, value-based business, including home-based services, care for dual eligible beneficiaries, urgent care centers, hospitals and post-acute care, behavioral health, and federal health services. This is about a $6 billion revenue business that affects thousands of clinicians and literally millions of people across the care continuum. From 2017 to 2019, he was president and CEO of Blue Cross and Blue Shield of North Carolina. And prior to that, he spent a significant amount of time in government, working in a variety of roles at the Center for Medicaid and Medicare Services, including as the director for the Center for Medicaid and Medicare Innovation, CMMI. Patrick is still a practicing physician, I'm happy to say. He remains a practicing pediatric hospitalist after some time as a leader at the Cincinnati Children's Hospital Medical Center. So without further ado, I'm going to quickly say, for those of you who knew me in my McKinsey life, I have a next chapter. I'm spending time at the Darden School of Business, where I am a faculty member and professor of practice. I'm also spending time as a board member for the Public Broadcasting Service, for Johns Hopkins Medicine, and for Signify Health. So with that, I'm not going to let Patrick make any snide remarks at the start about me. I am going to ask him to start with the fact that you and I have been talking about challenges in the healthcare system our entire lives, our entire professional lives. And I'm wondering, especially in this COVID world we're living in, what do you see as some of the biggest challenges we're facing in the United States in our healthcare system?
Yeah, so I'll break the rules and say we met 25 years ago when I was an analyst at McKinsey and you were already a rising star. So I'll call it out in the unscripted format. Yeah, the big challenges, and then I think we'll dive deeper into these. The cost is unsustainable. Like, we know this, and it's only getting worse, and it puts pressure on federal and state governments, employers and individuals and families. The quality is uneven. You mentioned one, we have amazing places where people come from all over the world, but we also can't seem to deliver basic hypertension care reliably to everyone, or diabetes care. And then the experience is quite poor, I would argue. If you look at other industries, it's too complex. NPS or other more specific measures of experience are poor. I think we've got a huge experience opportunity where you really have a consumer-driven healthcare experience that's simpler, better for everyone. And I think we'll talk more about this, but I think a huge opportunity in the future.
So, I would say that a lot of us have spent a long time trying to address these problems, but probably ending up more, if you will, admiring the problem, or being able to describe and define the problem. And I'm wondering, what would you do now? What are the practical opportunities to address these challenges and not spending our time admiring the problem so much?
Yeah, so, I'd call out a few things. And one, I think the move to value-based care, I think we're past sort of experimentation. It's, whether it was in North Carolina, which we'll talk about in my current role in Optum, it's how do you align a payment fully with care? So total cost of care, quality and experience. How do you have that over half of the payments? We literally, as you alluded to, we have 100 million people we care for across the Optum Health platform. And we're doing that largely in risk-based ways, including full risk for managing the population. So that's number one. Number two, mental and behavioral care, which we can dive into more. I think, fundamentally broken.
And I think COVID has really laid that bare.
No, I did. You can't make up timing in life. So I started in this role right before COVID, and my bosses, Andrew Whitty and Dave Wickman, said, we want you to work on mental and behavioral care and home care, which I was about to mention. And then COVID happened.
Perfect timing.
It's better to be lucky than good, as they say. So it was perfect timing, and it was a huge opportunity for our enterprise to really double down, if you will, or triple down plus in, virtual and mental behavioral care delivery, which became over half of our care delivery in literally a matter of weeks. We have a virtual care platform that delivered more.
You think that'll remain? We see this movement. Do you think it's going to remain that way?
I do. So I think we'll reset to a new baseline, but it will not be the baseline we were at before.
Gotcha.
So us, like others, a very small percentage was actually virtual or telehealth for mental and physical health. In mental health, I think you could reset to a baseline that is, 30, 40, even 50% virtual. We're actually seeing, when we talk to our customers, they prefer it in many instances, because they're not taking off work. They're not, there's still unfortunately stigma, which should go away, but they are able to access it, for example, when and how they want to, which has large advantages in their lives.
Absolutely. So any other things you do to address practically, not the theory of the case, the challenge?
Yeah, and I'm, despite being an academic at one point in my life, I'm action-oriented by nature. So, home care is the other area I'd call out, I think, in the near term. Our goal, and I think people across the system increasingly, is how do you care for people's physical, mental, and social needs in their home, whenever and however they want. So, our goal is literally, how could you care for any American in their home, whatever their physical, mental, or social need is? And we'll do that in full risk ways. So give you a tangible example. Even when you're giving our revenue, we're growing fast, so we got to update our numbers.
What is the number?
We're heading towards, it'll be greater than 10 billion. But more importantly is the people you serve. And so we are taking full risk on dual eligible beneficiaries, so the sickest of the sick.
And for those of us on this session, just to be clear, the dual eligibles are both.
Yeah.
I know you think you're talking to me, but we are talking to a larger audience.
So Medicare and Medicaid. So, by definition, sick, poor, and or disabled. And so therefore, really high healthcare needs. And we will take full risk heading towards, it's heading towards 100,000 members now, caring for them in their home and preventing hospitalizations and trips to the ER by, nurses into the home, televisits, meeting their social needs, delivering mental and behavioral care when needed. So that's where the system really needs to go.
Can I probe on this social needs for a moment? You've used that word multiple times in this conversation already. And I find that it's a word that's out there today, but it's a relatively new word to be married to healthcare. So how do you think about that?
Yeah, so whether you call it social determinants of health or social needs or drivers of health, speaking of things like food insecurity, transportation, housing, built environment. And we know these things actually have a larger impact on health by far than all the healthcare delivery that we pay for.
Right.
And so other nations, by the way, make larger investments in these social needs and public health, which may be a reason they have better health outcomes over time. And so I think we increasingly, and I did this in North Carolina and now in my Optum role, need to invest in these social needs: food, transportation, housing. And it can be connecting people to resources. It's not always that, the health insurance company or the provider provides all the resources, but there's a real issue in screening and then connecting people to resources and then knowing that need is met. It needs to be the same as I worked on e-prescribing when I was in federal government with Secretary Leavitt. which dates me, but it was like,
Yes.
we're going to have a system, imagine, where you click a button and the prescription is sent to the pharmacy, and then you pick it up and you know that it occurred.
And here we are.
We built a whole program, and
Right.
it works.
So that's one
it's got to
that's
be that way for social too, where it's
right.
the same idea, right? I order food and I know they got it and we can measure it. Sorry, go ahead.
No. This is important. So the e-prescribing example is one that did get done and did scale.
Yep.
But you and I both know
Yep.
of a lot of innovations that were really good, like in, one market and one system, but they never got to scale. It's not that we lack ideas, it's we lack ability to scale. Why do you think these things don't scale, and what can we do about it? What can we do to make the scale happen?
Yeah, it'd be interesting in your thoughts too. I think it's a few issues. I think, and I like working at scale. It's sort of what I've tried to do.
Certainly,
I think
certainly important.
Yeah, I think often we just get stuck in pilot mode of like, we could always learn more. So I think that's issue number one. Mark Harrison, I was kidding with him one time about like pilotitis, and other people have talked about this, that, you can always learn more.
I've not heard that word from you before.
Pilotitis. Yeah. I don't know if he said it or I said it first, but, and you just get stuck in pilot mode, and Such and Jane just wrote about this recently. So that's issue number one. And you just got to scale and start learning. Like, you will learn more as you scale, and you got to just keep going and realize you're going to adjust. So I think that's issue number one. Issue number two is, historically, but we're better now, we didn't have the incentives, right? I mean, people sort of, sometimes not you, but some can forget, if you can go back 10 years ago, it was a fee for service system. So it was aligned around volume. So you got what you got, which was, I remember, gosh, this was maybe 9 or 10 years ago, a big health system. It was like, we started a program to reduce readmissions. It worked. We stopped it. Like, literally told me.
Because we weren't getting
Because
paid.
we wanted the admissions. And you're
Right.
like, oh my gosh, like the incentives are heads in beds, like so backwards. No one wants to be hospitalized. And so I think now we're at a place where our incentives are flipped or flipping, which I think will allow these things to scale faster. The last thing, which, you alluded to board work, which I do as well. I think the capital going and the innovation in both the public and private sector in healthcare today is greater than I've certainly ever seen in my lifetime. So I think that will drive more of these changes to scale.
Terrific. So I want your advice, Patrick. I want to know the bets that you would tell me we're going to be making. So if you could place a bet on one or two changes in the next 1 to 2 years, and then let's look out over kind of the 3 to 5 year frame, and then maybe 10 years, like the crazy stuff. How do you think about timing? Because as you and I both know, pace, people made and lost money because of pace, not because of a bad idea. And, it's for patients who see something good, but it takes 5 years to get to them. I mean, what would you bet on in the next 1 to 2, 3 to 5, 10 plus?
Yeah, it's a great question. I'll try to be brief. I think 1 to 2, I think you will see dramatic shifts in the mental and behavioral system and in the home care system, including telehealth and virtual. I'll put those together. I think it won't go back to baseline. You'll see dramatic shifts over the next 1 to 2 years. 3 to 5, I actually think we're going to come to reckoning, I hope, from a policy perspective. Medicare trust fund, that's getting close to it, goes bankrupt. Now, in reality, we would avoid it literally going bankrupt. But I think we will see policy changes in 3 to 5 or 5 to 10. It's always risky to bet on policy changes faster. Where I think we'll see some changes in things that are being debated today. Should we have a different financing mechanism that looks more like Medicare Advantage? Is that earlier, et cetera? I think you'll also see continued sort of data analytics, AI really coming to more fruition. I never put that in 1 to 2 because people say 1 to 2 on that, and I feel like it's always taken longer. So I'll put that in 3 to 5 or more, if I can use that categorization. Yeah, no. Beyond 5, it becomes hard to predict.
You get to pick here a little bit.
And then Unfortunately, I'd love to say like we'll have an amazing consumer-oriented system in 4 years, and I will push as hard to get there as fast as we can. People have been betting on that for a long time, so I think it could take longer than we think. I just think we've got fundamental work to do around what does this system actually look like, and therefore how do you redesign the experience to be simpler, better, easier to navigate.
I will fess up that maybe a little after you met me, I wrote an article called Romancing the Consumer
Oh, nice
in
title.
the
You're good at
healthcare
titles.
space. I once worked promoting romance novels in another lifetime. And I remember writing the title and thinking, oh, by the time I am doing things like teaching at Darden, we will have a entirely consumer-based system. I think one of the big changes is how much more consumers have to pay out of pocket today.
Yeah, I think
And
you're right.
I think that could help. We haven't really spoken about that. That could
Yeah,
help.
I think it will. It has not yet, but I think it is an ingredient. We even saw this on smaller scales. We had something called Smart Shopper in North Carolina, but it was green, yellow, red, really simple. 100 healthcare choices you make. You pay us money, it's free. We cut you a check for $200. That was the difference between red to green. You change behavior because people were on the hook and it was cash and it was immediate. The moment they did the MRI at the lower cost place, they get a check for $200 and we saw people use it. So I think you'll see micro innovations like that scale.
Gotcha. So maybe now we should turn, we've talked about the big healthcare system, but we know that it takes leadership and individuals to lead organizations to help make these changes. As you think about the most important leadership characteristics, what do we need to make these changes? What are the most important leadership characteristics?
Yeah, and some of these hopefully don't sound too cliche. I do think you need to be bold and transformative in your change, especially in healthcare, but probably across industries. It's very tempting to make small incremental change. I think in healthcare and other industries,
Right.
The people, the leaders that really change the system, go for bold ideas that, by the way, don't all work. We can come back to that if you want. Personal health record pilots in Medicare. I launched it. It did not work, but someday it became blue button, and then it comes time. So bold, transformative change, number one. Related to that is willing to take risks. So both personal risk and organizational risk. And realizing it's not all going to be success, but you're going to learn from the failures and you move forward. 3, resiliency and persistence. And then you may ask another question when I hit on this, and we talked about this recently in a different format. I think there's something about strategic acumen combined with relentless pursuit of execution that in my life has been helpful, and I've seen in other leaders that creates sustainable change.
As you, I think, know from varying conversations we've had over the years, I do believe this magic and balance for the leader who can have vision and see where to go, but then not get so enamored that they actually don't get there. They take enough time to put on the less sexy stuff, but go make it happen.
The other thing I've learned from others, I'll just call out as one. I agree. And people talk about mission-driven or servant leaders. I'll take that a step further. That can connect that for them and their organizations down to the individual and family. Where I see the magic happen or the power happen, whether it's in North Carolina or Optum or CMS, is when those people in that org say, "I get it. If like we're working for like my neighbor in North Carolina or Massachusetts or wherever, and like I'm making a better system for them and my family, and I see the connection to the mission and the service." So when we can make those personal connections, I think it can really drive change in an organization.
So let's maybe turn then to this, your own personal leadership characteristics. When you have been most successful, when you feel like I am getting that balance of this strategic acumen with this ability to make it happen. What have been the ingredients? Like, what's going on with you when it's all cooking and working?
Yeah. I mean, I think of professional and personal flywheels. So I'll name some things and give examples. So when I first became chief medical officer CMS, literally the organization's like, I look at employee satisfaction surveys whenever I start. The center I'm about to have to lead is like second to last in an organization that's in the bottom quintile of the entire federal government, which is saying
Yes,
something.
I'm familiar with those,
Yeah,
surveys in the federal
yeah.
government.
You fast forward 5 years, we were number 2 in the federal government and got an award for Partnership for Public Service. You say, well, what happened? and the centers that I was responsible for were top box and CMS. A lot of small changes, but I think what we got right personally and professionally is you enabled frontline staff to drive change. You connected them to the mission. They saw vision, but with performance execution, meaning like when I have ideas, like this organization's moving, like I see the vision and I see it happening on the ground.
Right.
You do get the right people in the right seats, which requires, turnover and other things inevitably, and people notice that and see it. And actually every leadership job I've had, there's been a diversity component, which we could talk more about,
Yes.
not right leaders, right seat, but also a diverse set of leaders in every sense of the word, including gender, racial, et cetera. And so those are some of the component parts. Similar in North Carolina, I think we went from a well-performing organization, but literally believed we could be a model of what a blue could be.
Yeah.
And then, here, huge complex organization, but how do you connect all the parts? And how do you leverage that scale for change? And how do you when I get the most energy is when I'm problem solving with teams, which actually it's funny, McKinsey, that's what that's when yesterday I was talking about home health and how we're going to, reinvigorate sort of our whole home health system, including into the home. And that's when I get the most energy.
Terrific. You brought up diversity. I'd like to spend a minute on that.
Yeah.
When you think about why that matters, we read, there's been all kinds of published reports about why it matters, how it matters. It's not just the right thing to do. It's actually good for your business. What's going on when that's happening practically? Like, what do you see happen? Is the conversation different? I mean, what is it?
I do a couple things. So, and I could use here as an example. I'll use North Carolina. Just sometimes time and seat creates more change. So, Blue Cross North Carolina, our executive leadership team, when I got interviewed, and this is hard I hadn't been hired yet. The board said, what do you think of the ELT, the executive leadership team? And I said, well, there's 6 white males and 1 white female. And I looked up your employee stats, and you've got 75% women and 51% of people of color. So I'm guessing people notice the difference. Fast forward, we were 5 men, 5 women, multiple people of color. It did a few things. One, around that table, it was the most talented people, by the way. It wasn't just like.
No. I understand what you're saying.
But the conversation.
As I say, the talent is out there. The opportunities aren't equally.
Yeah. And the conversation shifts when you have a person around the table who grew up in rural North Carolina and then went on to Harvard and all kinds of things. She'd be embarrassed if I said this. But then Obama said she's one of the best people he ever worked with, and we hired her, and she is African-American female. She has a different life experience that is incredibly helpful. Yep. That same hire, I'm embarrassed I didn't know this. I started getting emails from the organization. And one of them came in and said, by the way, this company's been around for 100 years. I looked this up. This is a frontline call center rep that did this. We have not had a African-American female senior executive in this company in its 100-year history.
And you had to be told by the front line.
I had to be told by a frontline rep. I should have known that. That's on me. But it's not just about this one individual, although she's terrific. It permeates the culture that then if you're in that organization from frontline rep to middle management, you have role models, you have mentors, including people that look like you.
Yeah.
It's a cultural change that's a long change. And I certainly don't pretend to be an expert, but I do think we've got a big improvement opportunity as a business culture in this area.
So, Patrick, you've had some incredible successes, but you've also had some personal and professional setback. And one of the things we do in Leadership Unscripted is we don't just talk about everything that's gone great or all the things we know to do, but we also talk about things that maybe haven't gone so well. As you reflect on those setbacks, what are the ingredients that you believe led to those setbacks?
Yeah, and I'll tell a story, which I know you know, and then the ingredients. So, for me, I've had lots of failures that we could talk about. I think the most dramatic was over 21 months ago now. I made a decision on June 22nd of 2019 to drive after drinking with two of our girls. So this one's always still hard. And horrible decision on so many levels, but then it makes you reflect back, how'd you get there? And so for me, and I think a lot of people, it's micro decisions over time that you don't recognize. It's the bad boiling the frog analogy, although it's apt of, I was not doing self-care. I focused on family and work, but to the exclusion of, I literally used to say, like, I'll sleep when I die. And I thought that was like a badge of honor, which you hear people say things like that, which is why I mention it. Or, I can just keep, working no matter what. I don't have, stress never bothers me. I don't have to take care of myself. And so that led to a bunch of changes in my personal life, which we can talk about, that have incredibly positive effects on me and our family long term, and both personal and professional positive.
But you were not practicing those things then.
I was not. No, not at all. I was in the worst physical shape of my life. I've now lost 45 pounds through personal changes. Sobriety is important to me. So alcohol was a significant negative effect in my life that I've eliminated. I meditate every day, which I never had meditated, even though as a physician, these things, right? But like, I wasn't practicing them. I did therapy because I needed it. And so, everybody's journey is different. Obviously, you never wish for something like this to happen in your life. But for me, and I think this is true for many people's lives, when failures occur, it leads to changes. They happen for a reason. I truly believe that. And it leads to changes that are very positive long term. I do think you have to let go of the anger. Sorry for the long-winded answer on this one.
No. I'd like to, can you elaborate on that for a moment?
Yeah,
because, denial and anger often go with these situations. So say more about the anger when you obviously are not in denial because of the things you've been doing. But what do you mean by the anger?
And I think, here's what I mean by it. I think one, accept accountability and try to let go of the anger. It's not going to help you.
Right.
And it's not going to change it. And so you're going to have a period where it upsets you. Of course it did. It did me. I mean, it actually did some of my family, even at least as much as it did me. And some of, and you'll be like, oh, some of these things aren't true. Let it go. Move forward. We talked about this without naming them. I now have become a person people come to.
Yes. I was going to ask you, maybe I could push. What advice do you have for people?
Yeah.
Because if there are, a couple hundred people on this webinar and other people who are going to look at it, the law of numbers, it's just true. There's somebody on here who you could be helping. So what advice do you have for them?
Actually, I'll do a prevention advice and a post advice. Prevention advice, I had people, including you, who I had discussions with, who like, I should have listened more. That they're giving you warning signals, either directly or indirectly, or maybe you pick up on them, but like, listen to them. And, for me, I made changes for small periods of time, but didn't make those changes persistently. So I've now made those changes persistently, and I think about it daily, how this is important in my life, and I need to take care of myself to be healthy for myself and my family. And that's
You
not
want to
actually
fix the
selfish.
healthcare system, you have to be healthy in
Yeah.
order.
So your title was amazing. You came up with it. I'll give you credit, but I was like, oh, that's perfect. The other part I was going to say, I have tried to just move forward. And I've seen it where I was going. I've seen a couple examples where people, even as they talk to me about it, they're so angry about the past, they just can't move forward. And I think it's holding them back. So go through a period of anger, frustration, whatever the emotions are, like sit in that, but then move forward. And move forward in a learning, this is what I learned and how I'm going to address it. Look, I started in a new role. My was incredibly public. By the way, I also learned after it happened, I talked with our board. We did not go public right away because we wanted the legal process to play out. We should have gone public earlier. It's hard when you're in the moment. Once again, you can't change that now.
Right.
I was worried about the impact on my family, and I was following advice, and it is what it is. You got to move forward. And so, when I started here, we have 25,000 people in the various companies that report into me through the CEOs. I had to do a lot of town halls with a lot of people, and I just acknowledged it, said what I learned from it,
Yes.
and then move forward. And I've gotten feedback since that was the right approach. One, acknowledging it. To your point, I guarantee you, in this audience and every audience, there's people that have dealt with mental and behavioral health issues personally or in their family or otherwise. So I can't tell you the feedback I got that was really moving from people about the effect it had on them. And then you get to move forward from that, which I think is also an example of hope, if you will. And I still got work to do. I got lots of personal and professional development to do. It's not like I figured this all out.
So what do you do to sustain, and protect against future challenges? What do you think now as you look out forward?
Yeah.
I work to make sure X. What is that set of things?
Yeah, I mean, it's interesting for me. I really, and it's it's like almost hard to describe how much I changed. I literally think about what I need to do to be healthy each and every day, whether that like literally every day. I'll wake up and I'll meditate. I make sure I exercise regularly. I still work hard, by the way, because of my nature. But like, I'm present more with my family. I was with my family before, but I literally try to be fully 100% present, as and it's funny, meditation. I've gotten where like I can meditate, my heart rate goes in the 40s. That's like a physical effect, right?
Totally. I can't get it to 40s.
Yeah. The weight loss, people are like, how'd you lose 45 pounds? I don't even know. Like, I'm like, I don't know, just like I ate better. I didn't drink. I ate better. I did not drink alcohol, and I ate and I exercised. Like, it's like the things we tell people that sound ridiculously simple, but over time they create dramatic positive change in your health.
Right. So we're going to open it up in a moment for some questions from the audience, and I see questions building in there. But maybe if you were to go and give us advice about sort of caring for the health system, and let's bring it back to that. We've got a lot of folks on who either have an interest in the healthcare system, an interest in their own health, maybe they work in it as well. What advice do you have for us? If you can do something this year, not 5 years or 10 years from now, but what would you tell them this year? Hey, help us do X. What would it be?
Yeah, it's funny. Well, I'll call it mental and behavioral care, but I'm going to be a little more specific, which anybody can put into action. And I do all these little mentoring calls. I did one this morning. I said this to this person: drive change in whatever part of the system you're in right now, at whatever level. So like my first change job was like being part of running a unit in a hospital, and in government running like 10 people,
Wow.
which, but I was able, okay, this is my scope. How am I going to work with this team to drive change? And like, how am I going to measure that? How am I going to make the system better? And then I'm going to get, a larger and larger scope over time, but it's the same principles that apply. So people listening are probably at all different stages. That advice applies at every stage. And you see way too many people, I know you've probably seen this in your career, they just coast. Well, it's easier just to stay where I am because like the status quo is easier. And so try to resist
that's the very first thing you said about boldness. Like we need, so even in your own space, be bold.
Oh, I mean, and look, I'll say this. I don't think I said this directly. I applied for jobs. There's no way I should have gotten. Like,
and sometimes you didn't get them.
And I didn't get them all. That's for darn sure. But like, when I started as chief medical officer at CMS, Don Burke hired me, and credit is, I will forever owe him and Secretary of Civilians. I was 34. I didn't know, like, there were 200 years of federal service around me. There is something too about if you get a chance like that, try to come in a humble learning way. I tried to acknowledge, like, you guys know CMS and the federal government better than I do. I'll learn from you. Hopefully I'll bring a different perspective to the table. So I think there is something about putting yourself forward and really challenging yourself, being willing to fail, and then a continuous learning mindset around that.
Yep. Okay. So let me grab some of the questions that we're starting to get and ask you to respond to them. If you are someone thinking about transitioning into the healthcare industry, let's say from consumer marketing, or another arena, how do you make that transition? How do you think about getting someone to say, maybe you don't know healthcare, but you know something of value? And oh, by the way, take 1 second and define full risk. We've had a few people asking about that. So give me the full risk first, and then advice for those new to healthcare who probably had no idea what full risk meant.
Yeah, sorry. So full risk meaning the provider, the doctor, the hospital, the provider of care is at full financial risk in its most ultimate form for total cost of care for the populations of patients it's serving, quality and experience of care. So an example would be in our system, we will take risk for 100,000 Medicare Advantage members as the provider of care, the doctors, the clinicians, and we get a % of premium essentially from the health insurance company. To deliver that care, and then it's modified based on quality and experience.
Right, and when we're talking about managing costs, it's costs in general, but it's affecting everybody. It's costing me, it's costing you. So these full risk things have a way of trying to get back to the incentives aligned.
It aligns the incentives between the payer of care and the provider of care.
And ultimately the consumer of care.
And the consumer of care, because that's what you would want. To use the example we used before, then we're trying to keep you out of the hospital instead of.
Exactly.
And then on the consumer one is a great question. So encourage people to make that transition. We multiple organizations I've been have hire people from outside of healthcare all the time. I think it actually adds diversity of thought. So I love hiring consumer oriented people because we need more of them in the health system. You will have to find the right healthcare organization that thinks that way. I'm not going to tell you like every healthcare organization is oriented that way. Some of them will say, no, I only hire healthcare people. most big organizations, healthcare organizations like ours, are looking for people from the consumer industry, from digital, because that's, AI and data certainly doesn't have to come from healthcare. And then we apply that into the healthcare context.
Great. There have been people asking about both federal and state government action, and also about scaling value-based payment.
Yep.
Is this a state game? Is this a federal game? Is it both? I mean, how do you think about where this changes have to happen? And value-based payment is one example, but it may be other things.
I think it's public and private, federal and state, and I'll explain. When I was actually at CMS, we set goals, which I think mattered for the whole health system, which we then achieved in the Obama administration. And I was in Republican and Democratic administrations at different times. And the federal level, you can shift.
Actually,
Medicaid.
I don't think most people realize, Patrick, that were you ever a political appointee, or were you
Never political. I've got pictures in the Oval Office of me with Obama and Bush here, just so everybody knows. Bipartisan.
Anyway, go ahead.
Yeah, never political, but served. Actually, I've met and served in some way every living president except for Jimmy Carter.
Wow. Congratulations.
So, yeah, for better or worse. I think on the sorry, I lost my train.
Federal, state.
Federal, state, yeah. So federal, we set goals that were public, private, and then in Medicare, you have control at the federal level. So we were literally able to shift from 0% of payments in these value-based models to over 30%. It's now over 50%. And for Medicare, you really got the levers at the federal level. Medicaid is the levers at the state level. In North Carolina, with the Secretary of Health who ran Medicaid, my friend, Dr. Mandy Cohen, we were shifting Medicaid in the state payments. You need the private sector too, whether it's United Health Group, my current employer, or other private sector players. They need to drive in the same direction, because what matters at the end of the day to the doctors, the hospitals, the consumers in the system is if the incentives are aligned across the public and private sector to these new payment models. And I do think we're in a tipping point where in most markets now, you're heading towards or even exceeding 50% of payments in these models, which shifts, I think, the behavior, and we're increasingly seeing this in the market.
Gotcha. Do you think it's not just, though, what I'll call the federal and state action, but like operationally and culturally? I mean, you've done a bunch of these changes in markets.
Yeah.
What gets it to happen? Like, what are the things that you think separate out, some of the success that you and Rahul had in North Carolina with other markets? I mean, I'll give you guys, okay, you were bold and you were willing to do things, but you're not the only players in the game.
Yeah, it's a good question. I'll give some thoughts. I'll be open to your thoughts too. I mean, I do think you need some major players in a market willing to move, and preferably more than one. So in the North Carolina example, Blue Cross North Carolina was, 60+% of the insurance market, and said, we're going to go from almost zero to over half of our payments in these models in less than 2 years. And we did it. And we just said, this is where we're going. The state at the same time with Secretary Cohen said the same thing. This is where we're going. So I think if you were in that market with those two big players moving, like, it was clear the market is moving. And I think you see that in other markets, Southern California, long before now I work in Southern California, but it moved eons
I was going to say that you might be able to say long before you were born, but not quite.
No, not long before I was born. But I mean, with Margolis and others who I know, they very early on, right? You had movers in those markets that shifted, and so now they're in a different place. You've got some integrated delivery systems that have shifted the market in their pocket of America. And so I think you need some market density, if you will, that's willing to have bold leadership and drive this change with aligned incentives.
I lost you there for a moment. Are you there and
Yeah.
am I there?
I'm here and you're back. So I think
Okay, hopefully we're in good shape with our colleagues, and I think we are. I see that we
Yeah.
are. Sorry, everyone. There was a little freeze in our crazy internet world.
Yeah.
But maybe you finished the question.
Yeah, just I was saying I finished with just in markets. I think you'll have individual, some number of people in a market that create a density that want to drive this change, and I think you're increasingly seeing that.
Okay, terrific. One of the other questions people have had have been what I call the individual behaviors. So if you were going back to run a medical school and you were to reteach the doctors, and I have a member of my family who's just had the match, was last week. For
Awesome.
residencies and
Congrats.
internships. But
Yeah.
you're gonna, want to teach people. Someone wrote in the Q&A, how do you teach people to make good choices? Like and can we reconceive some of our healthcare training?
Yeah.
Towards, not just do X, but how to think about this. And have you had any thoughts on the rethinking of some of that?
Yeah, I mean, a few thoughts. And I still, when I practice, I still have residents and medical students. So, get to teach. I think a few things. I think one, historically, our system taught trainees, physicians, but also other clinical trainees, the basics of caring for the patient in front of you. That is important. It still needs to be taught. I'm not sure I needed to memorize the Krebs cycle 4 times. Now I don't remember anymore, so I'm not sure what the utility of memorizing.
What is it?
It's a biochemical cycle that I had to memorize in college and then in med school. And you're like, and that, when you think back of that, you're like, that was a waste of mental energy. So maybe we could redirect some of that mental energy. And my father was a chemist, so I'm sorry, Dad. Some of that to. Increasingly, I think you're starting to see medical students, medical residency, other train what I'll say in other sciences that are important: population health management, behavioral economics and incentives, measurement and quality improvement, basics of data science and statistics. Right. And I hope, and I think we're starting to see this, our training evolve in that direction so that you can both care for the patient, the person in front of you, which is still important, obviously, and is the fundamental ethos, if you will, but also care for the population of patients that aren't in front of you, which are often the ones falling through the cracks. So how do we identify them, care for them? How do we, care for them in their home and community? Any individual will have minimal interactions with their doctor every year. So how do we actually care for them outside of the office, in their home and their community through virtual care and other methodologies?
Gotcha. Thank you for that. You and I touched on how important diversity of perspectives is, but what we haven't spent any time on is the disparities in the healthcare system. I mean, you spoke about variation of access, variation of outcomes, variation of treatment, but how do we address the disparities?
So I was talking about health equity and moving from beyond, analyzing disparities to actually addressing them and achieving health equity. And so, in various roles I've had, including my current one, how do we address health equity and birth outcomes, where we've got real issues in this country in pregnancy and birth? Major disparities.
It's actually horrifying.
It is. No, we should be embarrassed. I mean, more than embarrassed. Horrifying is the right word.
For those of you on this session, just to be clear, we have one of the worst child mortality rates, and certainly for a developed country, it's horrible.
Yeah. Yeah, and worse in African American communities on pregnancy and birth, right? Yes. Which is, I know that's what you meant, but and so we got to address that. Like, it is horrifying. That's actually the right word. Like, it must be changed.
How do we do it though? I mean, one of the our
Yeah.
guests are saying, what would you do?
Yeah, so this one's interesting. I mean, we haven't totally figured it out yet. Let me give you some ideas. So, when I was at the Innovation Center, we did major investments in a program we called, it was a moms and babies program. There's a nurse home visiting program that we worked on scaling out. So we do have examples that have addressed health equity in states and localities. So I think it's how do you scale those nationally, which we have not done because the disparities still exist. Back when I was in Cincinnati, we literally would invest it. This gets to community care, zip codes. We analyzed, it's like this zip code that is where the real health equity issues are. So how do we work with that community in a community-based way, based on their needs, and address the fundamental issues with them, not upon them, but with them.
Yes.
And so that's the level we have to get down to, but then you have to scale that across, the X hundreds or thousands of zip codes in America where we have issues, which we have not done yet.
I can, one of the thoughts I've had is it kind of goes back to your pilotitis comment at the beginning, which is how do we actually get a few models that work, develop some archetypes?
Yeah, I think that's right on sort of the archetypes and scaling across communities. I think the other aspect we haven't talked a lot about is sort of the opioid and substance use issues in the country, where I think another example where we've got micro examples of what works. And actually, I started pushing on this back when I was in federal government in North Carolina and now here. But how do you scale those micro examples where you're really addressing substance use, everything from detection to treatment at scale? So that's another aspect to share. I apologize, everybody. Looks like Vivian had some technical difficulties as well.
Patrick, I don't know if you can hear us.
Yeah, I can hear you. Sorry,
Great.
I didn't.
Well, Vivian is coming back. We have another question.
Okay.
To another question.
Sure.
The question is, what does the healthcare industry get right overall? Tom is saying that he sees COVID-19 vaccine developed in record time and ventilators manufactured rapidly, so no one went without a ventilator. And are public-private partnerships with targeted federal funding the key to future leaps ahead?
Yeah, I do think public-private partnerships are key, and I think you're seeing more of that, and tried to hit on that in a few different realms. Vivian, we continued on. So this is what do we get right? So public-private partnerships, I think, is a critical component. You actually alluded to it, the vaccine. When you think about leading edge innovation, we get all kind, the vaccines in record times. That is an amazing example of public-private getting it right. And if you think about some of the leading edge treatments, when I've been at Boston Children's Hospital, Philadelphia, and Cincinnati Children's. You literally at those three institutions get children from 100 countries around the world because there's care that doesn't exist anywhere. Fetal surgery, literally, fixing things during pregnancy, which is like mind blowing. So like at the leading edge of innovation in US healthcare, there's all kinds of things to get right. For the for transformation at scale, I think I would go back to the public-private partnership, in every sense of the word, to drive the change we need for the population and the health system that we serve.
So we have another couple minutes, but not many. I have a question for you, if you don't mind my asking.
Yeah.
It's more of a personal one, but 5 years from now, you will have been sober for 7 years at that point, or almost.
Yep.
What do you want to have done in that time that maybe your personal travails you wouldn't have said 5 years ago? Like what's different now that you hope 5 years from now you'll have made that difference for others, for a community, for your business, for your family? I mean,
yeah.
What do you hope for?
Yeah, so it's interesting. Some of the goals have been the same, but I think I'm executing on them a little differently. So my career goal has been to change the U.S. healthcare system. I said that to my father 13 years ago when he was passing away. And he said, well, you're persistent. It'll be hard, but you're persistent.
And you're going to have to keep being persistent.
Yeah. So I'm still working on it. I've been in the Blues, I've been at CMS, and now I'm at United Health Group. So as we've talked about, those are those may be the three places to try to
three
drive
at scale enterprises, no doubt about it.
Yeah. So we'll still be working on that for sure. And I hopefully make a ton of progress over the next 5 years. Yeah, I do think the mental and behavioral system, I'm working on that right now. I've worked on it in CMS and in North Carolina, but this experience gave me, and some others I didn't talk about before this experience with my family, really in-depth detail of how broken the system is, and how much it needs to be fixed now. Access, evidence-based, everything from substance use treatment to serious mental illness to depression, anxiety to resilience and everything in between. So I hope that 5 years from now we can talk about that. And I think this sort of integrated delivery system that we talked about, at scale, home care. My personal life, I back when I was at Cincinnati and CMI, I had on my whiteboard, be a great husband and father. I think I'm better today than I was 2 years ago at that. And I hope to be better 5 years from now. And so, that's obviously what matters most in life. So I'm a spiritual person. We didn't talk much about that. That is still deeply important to me, and even more so after this. And then on the family part, I'd like to say 5 years from now that, our 4 children and my wife would say that they've noticed the differences.
Fantastic. Patrick, 25 years ago we met. Thank you for pointing that out to everyone. Thank you most for being with us. And I apologize for any technical difficulties. And to everyone who joined us today, we look forward to your further engagement with Darden School of Business at the University of Virginia. But we're going to respect your time and say thank you. And we hope everyone gets vaccinated when they are eligible, and that you have a great day or evening or morning, wherever you may be Zooming in with us. Take care.